I'm very grateful that I can talk here. So I want to thank Dr. Brendan McLean for inviting me to come to Ireland to give some talks, including the O'Connor lecture and also today here. So I want to thank also Professor Louise Wintro and Dr. Son Cornane for taking me also here, and so that I have the opportunity to make some publicity for my field. That's basically what I try to do today. So the title, as you can see, is Knowledge Gaps in Radiotherapy, and so I will talk about research opportunities. Some disclosures. This is collaborations with companies that I work with. Why should we do physics research in radiotherapy? Why is this interesting? And I've given reasons here. So radiotherapy is really essential in multimodality cancer care. It's blooming more than ever before. It's become very important in the field of oncology. Very important for us also is that technology and physics-driven research has been a driver for most of the major advancements in the past decades. I think, I'm modest here because most, I think, I would almost say all. It's close to all, and there is much more to do for physics. So that is why we can have much more impact, and that's why we should do it. What are the issues? So kind of global looking at the issues. Well, this is probably most people that work in radiotherapy research. They work on this problem. So cure rates are often not good enough, and radiation-induced toxicity is often severe. This is really the kind of core problem that we face, at least in the Western world. And so many of us are working on these issues, and I will also talk today about these issues. Another issue is that innovations in healthcare in general tend to be very expensive. And they tend to become too expensive, and we have to also work on making innovations without being expensive. And so there are several ways of doing it. I will discuss also some of them today. Well, an obvious one is automation, of course, but there are other ways. More elderly people, more cancer, and not enough personnel. I mean, if you read the Dutch newspapers, you get really depressed because, certainly there will not be enough personnel, whatever we do. So we have to be more clever, and automation there is also a buzzword, but probably more things. We will not be able to handle this. And I will not talk about that today, but this is also that has my interest. So there is an enormous upcoming drama in lower middle income countries. So the population there is also aging, and there is nothing, basically, to treat these patients. I mean, cancer comes with age, of course, and so it's a huge drama. So I discussed a little bit with Brendan before, and I understood that. Maybe most of you are not really into radiotherapy, so I decided to give some introduction in radiotherapy, which are called a crash course, some 10 slides maybe. So these are the modalities, main modalities that we nowadays use. So on the upper left you see external beam radiotherapy with photons or electrons. That is mainly done with photons nowadays, and the vast majority of patients that we treat in radiotherapy is now treated with photons, so with the upper left machine. Then there's brachytherapy. You put radioactive sources into the patient, and you see it here, and so cervical cancer example. And then there is a new one on the block, and that is proton therapy. And as you can see, it's a bit bigger, and new opportunities. I will talk a little bit on that. So, if you look at the differences in these modalities, a lot comes to those as a function of depth. And if you look on this slide here, so the yellow one here is iridium-192. This is used for brachytherapy. So brachytherapy, you are very close to the tumor, or you are even with needles in the tumor. So you don't need, you don't want a lot of dose away from your radioactive source. And you see it really stops very soon. If you irradiate with external beams, you want those at depth. So you have this kind of depth dose curve. So this is dose, this is depth. So you want those here to treat deeper-seated tumors. So this is a comparison with of X-rays. So this curve, the yellow curve here, and protons. As you can see, the protons, if you have a tumor here, look much better. I mean, you don't have this dose here, you don't have that dose here. So, I mean, if you look only at this picture, you would say, well, I mean, why do we still treat with photons, right? There is much more to this, and but that is kind of this is how you sell protons. So by showing this picture, and talking a little bit more about let's say the regular treatments, maybe 90% of the patients, I don't know exactly, treated with photons. So this is the machine again. So this is called the gantry. This thing can rotate, as you can see. So you can deliver dose from all kinds of directions. And so this, what you see here, is a CT scan of a patient, and projected on it is a dose distribution. So there are beams coming in, like here. So from this side, that side, and and in color is the dose. Red is always hot, means that there's a high dose. So in this case, all these beams overlap here, and here is the tumor. Yeah? So you get lower dose here. So I mean, so we're making these X-rays beams. They're produced with an electron beam coming this way, then it goes that way, and then there is a target here, and then there's a cone of X-rays coming out of that. And this cone is in principle circular, and the tumors are not circular, and they are not that big, they are smaller. So we need a collimator, and nowadays the collimators are multi-leaf collimators. They are put here, and you can see you can, for each direction, you can make a shape such that it fits with the projection of the PTV, with the target, so the tumor. Yeah, so I've noticed now myself, it can very well be that I use some words or terminology that you don't know. And so please interrupt, because it goes on and on and on. And so we can let's say, adapt the shape, but we can also adapt the intensity profile inside the beam. That also has turned out to be very effective. This is called intensity modulated radiotherapy. And so how do we do these intensities? Is again with this multi-leaf collimator. So from one direction, you don't give one field, you gave all kinds of subfields. And then, so in this case, 10 subfields for one direction. And then if you add up all the patterns, you get an intensity pattern like that. And so this is individualized, so made for the patient. Well, this is some nice distribution you can do. Maybe this is the most important here. So this is a treatment of a cervical cancer patient. So the cervix is here, but we also treat, in this case, we also treat the lymph nodes. And here is the small bowel. And small bowel is a very sensitive organ. You don't want to treat the small bowel because it gives you toxicity, one of the problems. So, so if you reduce the dose here, you have less toxicity, or a smaller probability that you get toxicity. This is the external beam radiotherapy workflow. So this is the common workflow with the photon machines. It starts with 3D imaging and contouring. So there is a patient, and you make a CT scan of the patient. There's almost always nowadays a CT scan. And the idea of this, what to do with this contouring, is that you get a 3D definition of the target and the OARs. The OARs are organs at risk. So you have to. This is for defining really your problem. And this is not at all trivial. Certainly, the definition of the target, so what you want to give dose to, is very complicated. So I will come back to that also later. So if you have this 3D definition, you load it into the treatment planning system. So this is a system making a treatment plan. And you see again these nice colors. The red is again high dose. So the idea of in the treatment planning system, what you do is you optimize the machine parameters. So you have this machine that you're going to use. It can have certain angles, the field sizes, beam on times, and that is all optimized in the treatment planning system. In the end, what you get is what you saw before, is an optimized dose projected on a CT scan. That is called the treatment plan. Yeah? And so this is the second step. So now we know how we want to treat this patient with this anatomy. And the third step is then the treatment delivery. really basically what is done is every day, so it's written here n times, so we're treating normally not 1 day but up to 40 days. So every day we load these optimal machine parameters in the machine, and then put the patient there and give the same treatment from the machine point of view. And this is also important for later. So there is also a CT scanner on this system. This is called a cone beam CT, and you can do image guidance. So we're putting the patient on a machine, but to do that accurately, we can use a cone beam CT scanner. Uncertainties are huge in radiotherapy, and to some extent they are solved, or let's say they are taken into account by using margins. So this is in the end what we're going to treat, but this is the real tumor. Let's say the visible tumor. This is called the GTV, the gross target volume. So it's gross disease, and basically that is what a doctor sees on images. On the CT scan or an MR, sometimes you have a CT scan, but you also include information of MR or maybe PET. Now this is what is visible, is this here. But then we know that, what is visible is often not the whole tumor. There may be tumor nests around that's what is visible. That is tumor, but you don't see it on images. So there is a margin for that. This is the dark blue one. So this is for microscopic disease, and the knowledge of that is from pathology studies. Yeah? So there were patients that had surgery, and they looked at the specimen and the surgical specimen, and then they find out, this is it's not confined. It goes outside the body. You can see it here nicely. This is a tumor. The tumor is way bigger. Is here. This is the capsule, and here is a tumor nest. And then the last one, another margin we are putting around it, is a margin to cope with geometrical issues. So a geometrical issue is, so as I mentioned, every day we're putting this patient on the treatment couch, and we have to do it very accurately. And but there's always inaccuracy involved, and so you need a margin for that, because if you're not actually sure that the tumor is here, but could also be a little bit there, then you have a problem, because then you miss the tumor. And so there's another margin going around here. So this margin you can you know it because you have been imaging in previous patients, so you know what the uncertainties were in these previous patients, and you can also do something about these margins with image-guided radiotherapy. I talked about that. This cone beam CT scanner. And so for treatment planning, so when we make these nice red blobs, these red blobs should fit with this PTV. So in the end, you irradiate a much bigger part of the patient than only this visible tumor. Yeah? And also bigger than the tumor plus CTV. So let's say oncologically, this is the real target. But we have to blow up this because we have other uncertainties. So in the end, there is a big volume. So this was how I started this presentation, and so making a list of what I could possibly talk about. And after a while, I saw that the font size became smaller and smaller, and I got more nervous and nervous. And so I had to make some choices. There are many ways to make choices in such a list. So what I did is, I can tell you a little bit. So I talked a little bit. I talked about topics that I know something of, I would say. Some topics I think they are very interesting, so I wanted to mention them, but it's certainly not my expertise. I also took, more, let's say, artificial intelligence, but also kind of building machines or building tools. There's also some biology in it, so I try to get some variation in here. So first topic is, it's only one slide, and then we go to artificial intelligence, which is a bit related, not fully. It's about big data. So I wrote it like that, so because in our field, we are very big in talking about the data, but the data are not so big normally. And so this is really exceptional, 20,000. And so this is a recent paper, and so what we need to do in this field, if we want to take the thing seriously, we have to do much more sharing of high quality multi-institutional clinical data to get really the data also big. And So this is especially true if we're talking about clinical outcomes, so toxicity or does the treatment work or not, this kind of things. You need really big data to. There's lots of studies that are really have noise levels that are terrible, and so if you want to start in this field, I would also encourage to, before you really jump into it, with the clinician or with Brandon, check him that his data are good. So there is lots of technical and IT issues. So I mean, there is reasons why this is going very not good, I must say. So there are lots of technical reasons, but there's also ethical reasons. There is GDPR. There is all kinds of things why this doesn't work. But this guy here, Andre Dekker, has looked at some aspect of that, and that is what I call information exchange without transfer of patient data. So he did a clever way that he could get the information that he needed, but there was no need to have the other data of the data of other institutes, because that is for all kinds of reasons often complicated. So I think what also, I mean, if you have these big data, we have to also learn how to, in the radiotherapy, how to work with these incomplete low quality data. Because I mean, if you just have data, so let's say the routine data there's huge amounts of routine data. If you just have them, they are really incomplete and they are of low quality, and that's probably also why you need so many. And so you want to really improve the data, but improving the data, in part, this is also workload related. So what we need is really scoring of clinical effects by the doctor, and that is really workload. And so there is also people that have worked on apps to let the patient fill out these questionnaires. So do they have pain today? Do they have nausea, diarrhea, whatever, and how often do they have to go to the toilet, and all kinds of things. Are they tired? So this year is really about data mining. There was a very interesting debate on the annual meeting 2 years ago, I think, of the European Society of Radiotherapy, and this was the title of the debate: data mining or data breeding. There's believers of this here, so a huge amount of low quality data, and there's also people that think, well, you better not focus on all these huge things, but do well designed studies to get good data. And probably it's a bit, I think in the end came out that, you have to do both and they have to a bit go together. Okay, next topic, artificial intelligence, deep learning. So this is, I mentioned, I talk a little bit more about this, but there are all kinds of different topics. So first some introductory word. Examples of recently investigated topics, deep learning for auto-contouring, so the specific application. So these doctors contour, right, in these CT scans, but you would like to do that automatically for several reasons, but the most trivial one is that this is a lot of work for them to do. And deep learning to establish normal tissue complication probabilities. So normal tissue complication probabilities are models that tell you for a certain dose, but also other predictors, for example, diabetes can be one. How big is the probability that a patient will get a complication? Normal tissue complication probability. They are models. Deep learning, I will talk a little bit, I will hardly talk about treatment planning, and that will be tomorrow, but today I will talk about a little bit about deep learning in treatment planning, not tomorrow. And some challenges and issues, and then some conclusions. So some introductory remark. So if you look at the field, you notice that the clinical use of advanced artificial intelligence is really in an early stage. So we are doing a lot of artificial intelligence, if you call logistic regression artificial intelligence, because that is what we do a lot. But if you talk about deep learning or complexer models, they are hardly used clinically so far. So it's very clear if you look at the literature that we have really found a new hammer. And now we are looking for all nails that we can find, and so there is really a lot of attempts of doing something useful. And well, as you can see, I mean, I think it's very promising, really, to some extent, some applications. So many of these nails or possible applications are about use of 3D images, and then a 3D dose distribution is then also an image, but also anatomical imaging. So there is a lot of attention for deep learning and convolutional neural networks related to these images, of course. Okay. Yeah, so this is kind of a list of investigated objects. It's by far not complete, but I chose these because I liked them, basically. And so mainly deep learning. And these are kind of applications that are quite close to the clinic. In the next slide is more physics. This is quite close to the clinic. So auto-contouring of tumors and OARs, I will talk about that later. I will talk about this one also later. I will talk about this one also later, so NTCP modeling. This is a nice application. I talked about this microscopic disease, right? And I mean, there is an attempt, there are more attempts, but this is one for glioblastoma, it's in the brain, a tumor in the brain, to, in some way, from the images, understand what the extent of the microscopic disease will be. You don't see it, but you try to understand how big it could be. So another important application is the response assessment during therapy. So suppose that you are giving a therapy, and I mean, we know that some patients will fail. I mean, they're doing all the treatment, and in the end, later, 2 years later, they have a recurrence. So maybe if you could already during treatment detect which patient will fail, you can adapt the treatment. Maybe give more dose or add something else, chemo or whatever. And so this is really important. Early detection of local recurrence for salvage treatment. Yeah, so as we all know, you hear that. I mean, the smaller the tumor, the higher probability that you can do something, right? And so, I mean, if there is a recurrence, you get also that recurrence fast, because then it's still small, and then there is better opportunities to do something for the patient. And then the last one here is distinguish progression from radionecrosis in follow-up. So, I mean, the patients get their treatment, and then regularly they see again the doctor, and then the doctor looks at these images and sees there's something, and then could be that there is progression, because I mean there is some strange things there, but I mean. It could also be that the tumor is really gone, but there is some radionecrosis or other processes where that make it look like maybe there is progression, and so these are very complicated things, because what to do now? And so there's attempts using deep learning to detect this. So this here, as I said, is very close to clinic, but well, the research is very close to clinic, but it's very far from clinical application. Because, I mean, there's a lot of testing and a lot of new work, new research to be done to find reliable models and also know the reliability of these models to do this really clinically. Well, sorry, this is done already clinically, but especially this part here is tricky. So these are other opportunities, and they are mainly deep learning. And so this is more physics. I will go very fast. Error detection and planning, prediction of QA things, convert cone beam CTs and pseudo CTs. These cone beam CTs, that you cannot do those calculations. You need a CT to do those calculations. So you convert this one. You measure it during treatment. You convert it into something that you can use for those calculations. Image enhancement of the quality of cone beam CTs is a problem. Generation of synthetic CTs from MRI is also an issue. So maybe you have heard of the MR-Linac, or more in general about. I mean, people are thinking of maybe not using anymore at all CTs, but you need a CT for those calculations. So if you only have MRs, you have to kind of generate synthetic CTs to do the dose calculations. So this is all quite successful. Deformable image registration, come back to that later. And then tissue classification, so you look at the CT scan. So, so in the CT scan, basically there is information on the electron density. But for protons, this is not enough. You have to know the atomic composition. And so there's people trying to figure out, or let's say to label voxels in the CT scan for atomic composition, and then you can do better those calculations in protons. Right. So now some more specific topics. Auto-contouring, as I mentioned. So this to replace this contouring that the doctors do. I already mentioned this one, very time consuming, and there is huge interclinician variation, so they don't agree. And so the current state of the art is atlas based, and this is really with limited success, and now there is deep learning, which that should do the job hopefully. This is a recent paper, 2019, and here, I mean, they developed a system for auto-contouring based on deep learning, and I will discuss very briefly a little bit of this paper. So what happened here? There were two radiation oncologists, two doctors, and there was a group of head and neck cancer patients, and in each patient they had to delineate 16 organs at risk. This is a complex treatment site, and so they had to do 16. So this is here, so manual delineation, so Dr. 1 and Dr. 2. But what also happened, so they had this system of deep learning, so they run the system. So there was also contours generated by deep learning, and these contours, they had to adapt them. So, or they could also leave them, but they looked at them and they could adapt them if they wanted to. And this is corrected delineation. So so if you now do a comparison, so apparently the time to correct was 33% shorter than manual delineation. This also means it's far from perfect, but anyways was faster. And interestingly, also what they saw is that this inter-observer variation here was much bigger than here. So if they kind of had an example of how it could be, they do not tend to correct so much. I mean, if they start from scratch, then, I mean, goes kind of all over the place. Not this is a bit exaggerated, but inter-observer variation is much bigger. So some conclusions. So there's better quality with deep learning. I mean, this is one paper. There's more papers around. All of that is far from perfect. Yeah, and another thing, and I will come also a bit later to talk about that. Contour need to be replaced by AI-based tumor characterization with multi-modality imaging and radiomics. I come back to that later. But the biggest buzzword here is tumor characterization, and so now what you do is you give a fixed dose to all voxels in the tumor. You suppose that they need all the same dose, and that is we know that is not true. But currently we can't do anything about it. We don't know how to interpret these images in order to verify, to vary in that dose. So this is a kind of this is a modeling study. It's not used in clinic. So what you see here is this is a parameter in a PET scan, the standard uptake value, and this is the dose that you should give. So the higher this value, the more dose you should give. This is the way, in the end, where we need to go in this field. So, switching again topic, deep learning for establishing of these models, NTCP models, so the probability that you get a complication. And this is also, here we are very proud, this is 800 patients, this is big for us. And so this is deep learning for predicting xerostomia in head and neck cancer. Xerostomia is also called the dry mouth syndrome. And if you say it like that, it seems to be quite a mild toxicity. It really is a huge toxicity. So these people have very much difficulty in eating. They wake up maybe 6 times a night because they have to drink. Social eating is really a problem because I mean they have very difficulty to eat, so they tend to isolate, and so it's really not a mild thing, dry mouth. So this is the applied deep learning network. So what goes in here is the CT scan, the dose distribution, and the masks of the organs at risk. And the answer is yes, no. You get it or you don't. It's as simple as that. This is an ROC curve. I mean, I don't know whether you know this curve, but the more it's like that, so the better it is. And it's quantified by the area under the curve. And so this is with their model, what they have. So this deep learning model. And this is, really you should compare it with this one, 0.7. So I think it's this orange one compared with the red one. This is quite an impressive improvement. It's not perfect, but it's quite an impressive improvement. And there's more examples that deep learning can do a better job. And so this one here, so what we normally do is done by, this one here is normally done by logistic regression. So it's a very simple modeling of the effect. Logistic regression basically is a neural network consisting of one neuron, right? So it's a very simple thing. And so if you make it a bit more complex, you get better output. That's really some conclusions. So current methods, you get moderate results, AUCs of 0.7. With deep learning, you get really promising results, not at all perfect, and there's also more external validation needed. Still a lot of work to do, trying to get better models. And hopefully, so try to get better models. I think there are some things that you have to keep in mind. I pointed that already before. So deep learning will help if modeling is the issue. And so if the simple neuron is not good enough to model the complexity, so you need more neurons. But I mean, you have to remember also with deep learning, if the data is not good or if you don't have enough data, and there's really limited what you can do. And this kind of work starts with good data. And also deep learning cannot compensate for missing predictors. Yeah, so normally the predictors that we use are very simple. So there's the dose distribution, there is kind of things like diabetes, like age, man, wife, this kind of man, woman, this kind of things. Very simple. There's nothing about genetics, for example. And maybe, people respond very differently because there is a genetic reason for that. So, so this is also something really interesting. I don't know what you could do here about this, but maybe in a collaboration with clinics you could. It's an important point. So deep learning and treatment planning, and again another topic. So I talked about delineation, I talked about these NTCPs, and now I talk about treatment planning. Treatment planning again is creating these nice pictures with good dose in the tumor and low dose not in the tumor. So current planning is manual. It's called manual. A better word is interactive, and you get large interplanar quality variations that has been demonstrated many times. These variations can be reduced with auto-planning, and this auto-planning is existing. Some auto-planning algorithms show consistent superiority relative to manual planning. Not all. It's the topic of tomorrow. So this is a kind of summary of the literature on deep learning for treatment planning. So the input is always a contoured CT scanner, so you have these contours there. The output is a predicted dose distribution. It's not a treatment plan. In the sense, it's only you get the colors, but nobody tells you how to make the colors. So what the machine settings are. And that is what's done nowadays. So you train these algorithms, they train these algorithms with manually generated plans. And these manually generated plans, coming back to here, are maybe not so good. Well, but deep learning basically interpolates between these plans, so maybe this predicted dose is also not so good. Actually, not so good. So some conclusions. So as I see the future, is that algorithm for automated multi-objective planning, and this is mathematics, this is not statistics like deep learning kind of things, will be the major driving force for plan quality enhancement and workload reduction. So I'm a strong believer in mathematics for this application. But I mean, there is options for deep learning, certainly. Deep learning, one of the very nice things of deep learning is extremely fast. And so if you want to be fast, you could do something. So you could do a fast dose prediction followed by a fast segmentation. You need an algorithm that is not deep learning, or you could also make this deep learning, or better even, a fast plan parameter prediction. No, not a prediction of the colors, no, a prediction of the segments that you have to use, the beam angles that you have to use. And I mean, there is nothing in the literature on this. I mean, we are starting up a program for this, and but not sure whether it will work. Anyway, I mean, if you want to use deep learning, I think these networks have to be trained with plans generated with this kind of optimizers. Otherwise, if you do it with suboptimal plans, you remain in suboptimal plans. Maybe a reinforcement learning. I'm not an expert in this field. I think, I mean, as I try to understand how it works, it seems that it could work. I have also seen other people talking about this. Some challenges and issues with mainly deep learning. I think maybe you know better than me, some of you. So, I mean, choosing these networks or creating these networks is kind of an art. So, I mean, it's educated trial and error, highly educated, I could say. Try would work with other applications, try would work for other people, and so there's something to do. This is kind of a very serious one, I would say, and that is these automatically selected features in deep learning are not intuitive. So there's an answer, but often you have no idea why there is this answer. And so there is issues with explainability of the network. And that, I mean, also in the context of GDPR, that can be a serious thing, a serious limitation, or maybe a prohibitive for clinical application. If you imagine, I mean, if there is a network telling you that, I mean, the probability of complication, a severe complication, is so high, you should reduce the dose. Well, that is, I mean, that is extremely far-reaching. That will have a clear impact on this patient. So, and if you cannot tell the patient, well, you know, you will have this or this, and that is why, for you, no. I mean, there is this deep learning algorithm that is kind of all kinds of nice connections. There's a big brain in there, and who did it for you? But the brain doesn't tell you why. And there is also issue with generalizability of models and local validation. I come to this. This is a nice paper about generalizability, and this is in Nature. It's in this year. It's not about radiotherapy. I think in radiology they are a bit further. The problems are much easier in radiology, but so they use they have developed an AI system for breast cancer screening. I couldn't find it in the paper, but I think this is a system by Google. The first author is from Google. Also interesting, and so they had a system, and they initially trained it for patients in the US and UK. So I mean, they gave it images, and then and they trained it in a way that, I mean, there was a tumor or not, right? And it was really that is really nice. I mean, it was really better than the radiologists. I mean, there was no doubt about that. But I mean, this is something to keep in mind. So in the US, the performance was better if it was not only trained with UK patients. And maybe you would think, so you needed to train it also with some US patients. And maybe, kind of, if you don't think, maybe I think wrong, but if I think maybe it looks kind of, I mean, it probably is better. Yeah, but why is that? In the paper they don't have an explanation for it. Maybe something to relate it very subtle, like image quality. So that the image quality, there was differences in image quality, very subtle things that it was still better. I mean, also with only UK patients, the system was better in the US than the radiologists. But if you include the US patients in training, it becomes even better. Yeah. Tricky. Summary conclusions. So I think AI has great potential to make a difference. Lots of challenges, technical and legislative, regulatory. So there is lots of research questions. This is the topic of today. Yeah, I think there will be a first broad clinical use of deep learning for auto contouring. It's already ongoing. There are already commercial products that have that, but this is really far from perfect. We have to work more on this in this field to get it better. Yeah, important to remember this, of course, garbage in, garbage out. It doesn't work on the garbage. Yeah, more explainability we need. I try to make that point also, and generalizability is also really to take something into account. I think for the more complex decisions, certainly if there is little way of explaining it, you have to really locally validate the model, and we also have to learn how to do that. Data sets in a small hospital are small, so it's not that simple, and so I think there's a lot of research questions also there. Okay, other topic. Well, it's all related. Personalized medicine, we like that. Or nowadays, this is already old-fashioned. Now it's precision medicine, and so precision medicine, adaptive radiotherapy. Yeah, so. This is maybe this. If you are able to solve some of the problems I'm going to talk about here, even for one tumor site, you are a winner. And so this is about characterizing, delineating a tumor in scans. So what we need to work on is parametric imaging for tumor segmentation. So you use different sequences of MR, maybe different traces of PET, the CT scan, maybe dual energy CT, whatever, and for tumor segmentation and preferentially for characterization. So that's one part. So there's multi-parameter imaging, so different modalities, different sequences. Then there's another way of looking at these images of tumors, that is radiomics. And this, I will talk about that later, is for quantitative tumor phenotyping based on imaging. I will explain what it is. It's nothing related to biology. You look in a different way at images. So, if you have solved this, this is an increasing level of sophistication. These are the big winners. So, but if you can substantially reduce inter-observer variation in segmentation, you will be famous. Much better is that you can. This should be up. If you should increase the segmentation accuracy, and so sometimes all these clinicians they agree, but they're all wrong. That is also not so good. So this is better. Even better is, if you look quantitatively at these images, and you can you find biomarkers. So, for example, a biomarker that, if you, certain sequences, you see some coloring, and that tells you, well, this is a very aggressive tumor. Give more dose, or enter some other treatment also. So that is even better. So the best is this dose splitting that I talked about. So every voxel, this should be the dose. Oh. Yeah, next topic related to personalized medicine and adaptive radiotherapy is treatment planning. So we have to personalize treatment technique much more than we do, and also have to much more look at patient-specific balances between objectives. There's a lot to gain also here. There's not enough time to really go into detail here. So this adaptive radiotherapy, have you heard about MR-Linac or no? So that is a treatment machine, a photon treatment machine, but there is also integrated an MR. So instead of these cone beam CTs, you use an MR, which has much higher soft tissue contrast. So it has a much more potential. And so this daily plan, why do you want to adapt? Well, so these patients are not, they are not bricks, right? They don't have a fixed anatomy. So, if the rectum is more filled or the bladder is more filled, that's all an impact on where this tumor is, right? And also, you cannot always, with a cone beam scanner, cone beam CT scanner, you can do translations. But if the anatomy is very deformed, you cannot correct with a translation, right? And so you want to daily adapt the treatment plan. But this is related to the daily adaptation. You need to do deformable image registration, so you have one anatomy of today, the anatomy of tomorrow, but in some way you want to integrate that and add those. So you need deformable image registration for those accumulation. And the last one that I want to mention here in this world of adaptive radiotherapy is daily biological imaging. So there are now a couple of these MR Linux around, and people trying to do that. So every day they do contrast imaging. I don't know, diffusion tensor imaging. I don't know, all kinds of imaging they do per day, and hopefully they find something something changing, and that kind of predicts maybe of how well the treatment will be going, right? Okay, radiomics. This is a few words about radiomics. So this is about tumor phenotyping. So you just look at the phenotype of tumors. How do they look like? So there's parameters that have something to do with shape. There's histograms of gray values, textural features, and then filter-based features. So this is nothing to do with biology. You look at patterns, really. It's kind of pattern recognition. And so you describe phenotypes with that, and so these radiomic features, they may predict for treatment outcome. This is the idea. And so this is a very complex thing, and so the generalizability of this is very difficult. I mean, also for the tumor, it depends on how you delineate the tumors. If you make it bigger or smaller, it has all an impact, and so it's really an issue. So this field started in 2012 and has become really big. And so with the capitals big, but not in clinical application, but the number of publications has really grown. And so this year came this paper, very painful paper. So this paper is on one of the, let's say, the pioneering papers on radiomics, kind of defined the field. And everybody started doing it, and it was wrong, that paper. And I can briefly tell you what was wrong. So there was a signature, radiomic signature, had 4 features, I think. One of them was tumor volume, and in the end it turned out if you only used tumor volume was equally good. So all these nice things. I mean, I have not had yet time to read this paper, but I don't know what happened, how this is possible. They had a very smart trick, I saw that, how to find it out. I skipped this because of time. Yeah, maybe this is another, this is proton therapy. You see a huge machine, and so this is the patient is here, so there's a huge thing, and this is the gantry, so to make the proton beam move, or rotate. And so very expensive. Maybe most expensive is this part here. So there's people that came up. This is a recent paper, 2020, and so combined proton-photon treatments, a new approach to proton therapy without the gantry. So basically, what it did is there's a treatment room. There is a normal LINAC for photons, and there is only a horizontal proton beam. That's it. No movement. And then they try to combine the things. And they got really good dose distribution, interesting dose distributions. So this makes it much cheaper. I mean, coming back to one of my first slides, that things got too expensive. And maybe this is interesting solution. So, yeah. So here I wanted to, maybe if you give me 4 or 5 more minutes, I want to talk also a little bit about biology. Toward biology. So radiotherapy and the immune system. So there is a huge interest nowadays in this combination. And this is a very interesting paper. Also, I mean, there's also physicists involved in this work. And so it is about partial volume irradiation of tumor. So you don't irradiate the whole tumor, you irradiate part of the tumor. And, well, for time I will not really fully explain these graphs, but what they see is that if you have this is about mice. If you have mice that have they have an intact immune system, then what they saw is you can equally well irradiate half of the tumor or the full tumor. Doesn't matter. And this has a big, I mean, if this is really true for all tumors, I mean, then I don't think so. I'm quite sure not. But because, I mean, most of what we the clinical physicists do is make sure that you irradiate the full tumor, right? And this paper says if you can also irradiate half, and this is if you have an active immune system. So they did it also with mute mice, and then it doesn't work. So you really need this immune system to kind of make up for not treating half of the tumor. Very interesting paper. I mean, I don't know what the consequences are of this, but anyway, flash radiotherapy. Yeah, that is also a new one on the block. There are believers and there are people that are very skeptical about this. Also because maybe it's not really known what the mechanism could be. I mean, there is some mechanism. Talk about that. I mean, I think it's clear by now that radiotherapy needs protection of healthy tissues. You cannot irradiate the tumor and not irradiate at all the organs at risk. You have to minimize that, otherwise you get complications. And so there basically nowadays are two ways of doing that. There's fractionation. I didn't talk about that, but basically that, I mean, if you don't give the full dose in one day, but in more days, you relatively spare the organs at risk. Yeah, so you get a better sparing, less toxicity. And then the other way is what I talked about a lot is high precision tumor targeting. So by treatment planning, by image guided radiotherapy. Yeah? So keep the dose in the target and not outside. These are basically the two ways to protect the healthy tissues. And now there's the third way. And I mean, yeah, let's say some say it's not clinical. Well, there's one patient treated, and so this is flash radiotherapy. So this is treatment with ultra high dose rates and really high. So I mean, this is what is needed compared to what we do normally. Yeah? So this is some difference. So it's really, and then you better do it right, otherwise there's no correction. And so some words about this flash radiotherapy. And so you get less toxicity for the same dose, and the tumor effect remains the same. Yeah? So you give one dose. If you do it very fast, then there's sparing of the organs at risk, but no sparing of the tumor. The tumor is okay. Tumor you cure it. Yeah, and there is a number 1.4. So you could also put it the other way around. You can give 1.4 more dose to the organ at risk to get the same toxicity. So it's not a minor thing, right? It's a big thing. So I mean, this has been demonstrated mainly in electron beams, and the reason is that electron beams you can relatively easily get these high dose rates. And so there have been experiments in cell, animal experiments, and so I told you there is one patient that has been, and was a huge success. This patient. Well, there's no time for details. Maybe some come to the drinks tomorrow evening. Then dependency on time structure. Yeah, this is really something. I mean, this is way too simple to characterize flash. So there is really there's really a lot to do here, because I mean it's seen that within pulses you have these again peaks, and all that has an impact on the final effect. So biological explanation. So this is one that people have been talking about. So the idea is that if you irradiate a normal tissue with very high dose rate, you will induce a hypoxia. Hypoxia means that there is not enough oxygen. If there's not enough oxygen, you cannot really create damage to a cell. Yeah. So I mean, you give it that fast, then you get so in some way there is the oxygen is not active or cannot be used or is used for something else, and so there's no oxygen to really fix the damage, and then there is no damage, and the tumor, many tumors are anyway hypoxic. So I mean, it doesn't matter whether you treat them with flash; they were already hypoxic. So that could explain the differential effect. That's what they talk about. Well, there's no idea how this would work together with fractionated treatment. Larger tumors, no idea. Multiple beams, no idea. Yeah, there are also a lot of studies about suitable treatment treatment units. So if you're interested in more building things, that could be also an interesting topic. Yeah, I think for time I will stop here. If you ask